We are excited tonight to welcome Dr. Eric Schroeder, who will present The Coughing, Runny Nose, Poor Performance Horse, New Perspectives on Equine Asthma, RAO and IAD. Dr. Schroeder graduated from the School of Veterinary Medicine at Michigan State University in 2007. He then pursued an equine internship in a large private practice in Lexington, Kentucky. Post-internship, Dr. Schroeder was fortunate enough to land a residency at Michigan State University in both large animal emergency and critical care and large animal internal medicine. His current position is an associate professor in equine emergency and critical care at The Ohio State University Equine Medical Center. Welcome, Dr. Schroeder.
Hi, everyone. Thanks for inviting me to come and talk to you tonight. My goal tonight is to hopefully talk to you guys about some new perspectives on asthma, et cetera, in a horse, something I definitely see on the emergency front and as well on the internal medicine front. If you can, Julie, I'm assuming you can see this. Okay, perfect. All right. Write your questions down. I'm happy to spend some time talking to you guys after the lecture and try to get as many questions answered as I possibly can. Okay. All right, so a few goals for the presentation. Going to talk about recurrent airway obstruction, and most people know this as well as talking to you a little bit about inflammatory airway disease. We have lots of acronyms for these diseases. So recurrent airway obstruction now is called severe equine asthma versus inflammatory airway disease is known as mild equine asthma. Historically, I'll talk to you a little bit about these diseases, and then I'll talk about the kind of the pathologic or pathophysiologic manifestation of it, and why do we really care about it? Because that's a lot of how we attack to treat it. And then last, I'll finish up the talk talking about kind of current management strategies, both what we have for environmental control, as well as ancillary meds and rescue meds. Julie, I'm going to try to get, I don't know why it's not showing my face. So let me try something here. Maybe I'm not going to be able to do it. I don't know why it's not picking me up, but as long as everyone can see me, I'm cool.
We can see you and hear you.
Oh, you can see me? Okay. Because
Yeah.
all I see is you. Anyway, okay. Sorry about that, you guys. So one of the major changes that has happened with this disease in the last about 5 years is we've really changed the idea that they're very different diseases. And now it's in essence one giant spectrum of disease. And on the most simplistic end, mild to moderate equine asthma. And then on the most severe end, severe equine asthma or in essence, RAO. I'm going to try not to make it too scientific, but I thought a brief trying to explain what is going on in the horse's lower airway disease, because both of these diseases, while they affect the lungs, we call it lower airway disease. So the pathology is happening down here in the lung tissue versus upper airway disease, which is affecting basically the larynx, nasal passages, and the trachea. And that would be, in essence, your roars, your dorsal displacement of the soft palate, dynamic airway collapse, etc. So the manifestation of this disease is quite different, and it only affects the lower airways down here, and the upper airways up here are basically normal. The tissue that we're most concerned with are these sac-looking things over here. Sorry, it's a bit blurry, but those sacs are what we call the alveoli, and that's primarily where this disease uh, rests. Uh, to explain, this is a horse's windpipe right here, known as the trachea. And these are in essence race horses. Over here we have pre-race completely normal, and then post-race completely normal. And then if I did washes and stuff like that, which I'll talk to you guys about. So if you have horses that are affected with heaves, RAO, I'll talk to you about how as a doctor I diagnose that. Basically, the lung cellular material is fairly normal. If we switch gears and we talk about the asthmatic horse and we look at um, uh, the pseudo normal asthmatic horse over here, you can see the windpipe is quite inflamed and thickened, etc. And as they mature, so to speak, and even post race, I can get these guys to have quite significant more exacerbation of pathology. And then down here in the lower pictures, these are all inflammatory cells sitting here. And I'll go into a little bit more detail about that as we go along. But please remember, this disease only affects the lungs and the lung tissue itself versus other disease manifestations. Uh, they affect the upper airway. So if we go all the way back in time, these diseases really affect the the airway, so to speak, of the horses. And it's been talked about for a long, long period of time. Um, back in the early 1900s, we actually had a guy at Ohio State that talked about airway disease in horses and started describing these horses. And he just said that they have, in essence, chronic emphysema with a predominance of overdistension of the lung. And how ironic that over 100 years ago they were already labeling or using the terminology as heaves, and they came up with the term heaves because they had to heave their abdomen in order to get these horses to exhale. So they would say that these horses had a forced expiration. They tended to have coughing fits, and then they had evidence of double movement of the flanks. And I'll talk to you guys a little bit more about what we mean by that. And all the way back then, they were assuming that feeding of dusty feed was a huge predisposing factor. Some other textbooks all the way back then even talked about, horses require pure air, so to speak, to breathe, and they need to live in well-ventilated stalls. And allowing them to breathe steam from buckets of boiling water would help them as a treatment modality for this. So it's quite interesting that realistically, while we've made some advancements as far as trying to figure out how these diseases become manifested, a lot of the treatments that they have come up with are quite old. And then even in the 1800s, in a textbook, we have a gentleman that was describing these heavy horses as having broken wind syndrome, and it resembles human asthma. And all the way back then, they noticed that there was significant pathology, and they were already starting to make this similarity between the horse and the human. What we now know is that they're quite dissimilar. They're not really quite the same as human health asthma. So fast forward in time, now we are considering the IAD, or the mildly affected horse, versus the severely affected horse versus the mildly affected horse, as both being inflammatory style diseases in the horse, but they are not sick. And that's really, really important to realize, and something that we battle with as veterinarians on a daily basis. If you're wondering about this picture, this is the Dust Bowl in 1930 out on the plains, and this is what they were breathing. We also know that there are broad causes for the disease, a lot of things that have similar liking to how the disease is caused. We pretty much know to date that this is a disease of domestication. And what do I mean by that? We expose these horses to varying styles of a closed-in environment, whether that's in a barn, etc., or the style of environment that they live in, whether that's in the south where it's really hot and humid. And then we feed them very different feeds than what they were quite accustomed to when living out as a range horse. And again, if you go back not too many years ago, we talked about it as two different diseases, and now we're basically calling it one disease. To explain this picture here, this is actually my own barn at home, and it doesn't take very much to get cobwebs in your barn, and those cobwebs are a great example of the ability for them to trap dust, so you can figure out how dusty your barn is. Here's a great picture, unfortunately, of a really moldy round bale. So horses may be exposed to this disease that way. So, like I inferred, it's not really two diseases anymore. We used to consider that they were very separate and they were on a timeline, so to speak, and that was very longitudinal, and they were likely to go from having one disease, inflammatory airway disease or mild asthma, and then continue on down the line to develop later in life, likely severe equine asthma, otherwise known as HEAVs. Now we know that the data is basically saying that these are a blend, that not all horses that have inflammatory airway disease are going to go down the line and develop severe asthma as they age. To bring some light to previous names, you guys probably know a lot of these. HEAVs is extremely common. It's still used today. Other things, people would call it equine emphysema. It's not really an emphysematous style disease like what we have with smokers' lungs and people or coal miners' lungs. We would call it chronic obstructive pulmonary disease. Again, we don't really use these terminologies anymore because based on the histopath or biopsies of their lung tissue, it doesn't match up quite as nicely as what it does on the human side, where there's a progression. So where are we today? As stated, equine asthma has been around for a long time. It's been described in literature for over 100 years. Now we're getting a little bit better at tying things down to being more of a complete spectrum of disease that probably doesn't have a lot of linearity to it. We also know some data and have some rough ideas of how many horses that we think it affects out there. Rough idea is we're saying that it probably affects about 25% of horses in the northern hemisphere in temperate climates, etc. We can exacerbate this disease depending on what part of the world that we have horses living in and what type of environments that that they're in. And again, most of it is a syndromic style description of the disease, and we're trying to get away with putting guardrails, so to speak, on how we talk about them, etc. Knowing that there's a huge different spectrum on each horse, and each horse is separate from another horse that may have these diseases. Okay, so broad definition now. So we went from stuff that's very narrow to actually broadening the definition out. We know that it is basically chronic lower airway disease that we are faced with. And again, I cannot anymore really say that one horse, if they have inflammatory airway disease, are going to continue through life and to go on and develop severe equine asthma. We also know that there's significant amount of structural change that goes on in the lung. I'm not going to talk about that at all in this lecture. In the spectrum of disease, like I said, is not legitimately right now that we are thinking of it as a continuum. Okay, so like I said, it's chronic airway disease, and it's basically due to how we do things. Like this is very common, okay? Horses with a common IOA, a very small door on one end, hayloft above, and not a lot of air movement through here other than through a tunnel. Same is true in this race barn right here. Pretty classic for winter time. at least even in Ohio, to have race barns closed up and not a lot of air movement through it, and likely no windows in the back, versus something down here, how we're trying to design horse barns now to have lots of open airway ventilation, etc. So again, in essence, I have brought this disease on by domestication and convenience sake for how I house animals and make a human life easier, and not necessarily making a horse life easier. So the big takeaway is their breathing zone is typically highly contaminated. What's it contaminated with? Barn dust, mold, pollen, allergens, noxious gases from manure, and urine from the horses. Other non-specific irritants, if you have tractors driving through the barns, etc. And then other exhaust smoke, if you have heaters in there and whatnot for the wintertime. So, one of the main things as a doctor that I have to do is try to get an idea of what's going on in the horse. So, we spent a lot of time trying to decipher what these animals look like at home. Because most of the time, usually when they come to me, whether it's on a medicine case or an emergency case, they're quite severely affected. Um, so I need to know, is it seasonal or not? I also need to know, is there an exercise component to it? Is the horse really bad at the start? Is it coughing a lot? Does it quit at the quarter-mile pole if it's a racehorse? If it's having significant quitting problems as a racehorse, whether it's a trotter or pacer, if it's a standardbred versus a thoroughbred, or this disease is pretty prominent in the barrel racers as well. I need to know, or is something else happening in their upper airway versus the lower airway? So this DDSP, so that's dorsal displacement of the soft palate, is something that I see in these racehorses based on how much they are working their airway. So do I have two disease manifestations going on at one time? Is a cough present? And did anyone do a rebreathing exam on it, or is that something that I need to do? I'll also ask them, is the cough persistent through exercise or only at the beginning? Is it productive or not? And then also, some of these horses will have nasal discharge. Is that normal nasal discharge, or is it abnormal and really purulent with a lot of exudate? Other things that I want to know, is this the first episode that the horse has ever had, or is it a recurrence? If it's a recurring thing, how often is it happening? How is it happening? How do we manifest it? And have we done any changes? Um, Other things that I need to consider in these horses are how's it managed? What type of diet is it on? Is it on a predominantly hay diet? Is it on a complete feed diet? What type of grain is it fed? Is it really dusty grain, etc.? I usually ask people to take some videos of their barn to give me an idea what type of stall confinement do they have. Do they have all kinds of barn dust like this? This is actually swept out of a hay mound. These are all 5-gallon buckets full of barn dust. Or do we have something like this with these huge fans at the top, wide open airspace up here, lots of air traffic, etc.? I need to know about the bedding. That's a huge inciting cause of this disease. What type of turnout? How do they ride the horse? Is it ridden in a dusty arena? Is it ridden outside, etc.? Do they have fans in the barn? Where are the fans located? Are they on the stalls? Are they blowing directly on the stalls? Are they blowing down from the top, etc.? And then last but not least, and the thing that most people hate to talk about, and that's dust management. So how do they clean their barns? Other things from a vet side, I want to know about their current treatments. What are they doing? Are they doing anything for it? Is it on any medications? Is it on nutraceuticals versus pharmaceuticals? Have they worked? I.e., has the horse gotten better or not? Um, uh, and I need to also consider about compliance, meaning can the owner get the medication into the horse, or is the horse starting to be reluctant to take the medications, etc.? And how are we going to be able to potentially medicate these horses in crisis or keep them on long-term therapies, et cetera? So as a doctor, I need to consider one of the main things, how expensive are the drugs? And can they give it a route that is both safe for the owner as well as safe for the horse? And then how frequently do we need to administer it? It's great that I have all these drugs at my fingertips, but unless I get them into the horse, it doesn't really matter. Okay, I'm going to shift gears now and go away from a little bit on the history side, and I'm going to talk a little bit about some of the clinical signs for mild equine asthma or inflammatory airway disease, as we used to call it. So it's typically a combination of significant airway inflammation and excessive mucus production. And that mucus tends to accumulate within the upper airway and trachea of the horse. A lot of times, the lower airway, while this disease in general is a lower airway disease, I don't see a lot of huge pathologic problems there. Sadly, even still to this day, with all the testing that we have and ability to look at varying ways of trying to diagnose things, I don't have what we call a great etiopathogenesis for this disease, meaning I don't really have a root cause, other than that it's likely multifactorial, which from an owner as well as a veterinarian can be very stressful because it may be different for every single horse in the barn. So that's why I really need to take into account all the things about the management of the animal, potentially its age. There is some evidence about susceptibility of certain types of breeds, etc., and then how the owner uses the horse. So some generalizations for asthma on the mild side, so inflammatory airway disease. These horses tend to be any age. They usually are on the younger side, but not always. There's no real sex predilection for it. The occupation can be all over the board, meaning what they use the horse. And usually they're in about every single breed. Now, granted, I haven't seen a whole lot of draft horses that have this, um, um, but they tend to have other problems that can exacerbate this. Common risk factors, stabling in conventional style barns, hay feeding, exposure to organic debris and gaseous particulate in the stalls. Genetics may play a role in it. We are getting a little bit better handle on previous viral bacterial infections, with herpes being one of the major ones. And these horses usually have a cough. They may not have any other signs. So if I have a horse that comes in as exercise intolerant and a cough, I am starting to think that they have mild forms of asthma. Traditionally, if I were going to do some lower airway a diagnosis on these horses, in the literature, they would say I would have the vast majority of the cellular debris there that are all abnormal being in the form of all the inflammatory cell marker lines, which are the neutrophils, the mast cells, and the eosinophils. And the BALF, it just stands for bronchoalveolar lavage fluid. Um, so I can see a lot of abnormal cells in these horses, but they don't typically have a lot of overt change to the macrostructure of the lung. If I were to compare the two side by side, so mild asthma here to severely affected the asthmatic horse, you can see a lot of these have a lot of the same things in there. So it does make it a little bit difficult at times in order for me to separate them out. So again, age for the mild asthmatic, it's usually a younger horse to middle age. However, if you look over here for the severely asthmatics, some of those can be as young as 7 years. Clinical signs, something that I lean on heavily. A lot of times they have coughing, poor performance, but not significant increase in resting respiratory rate. Most of the time, these clinical signs are kind of ongoing. They never usually go away. Versus the very severely affected horse, the severe asthmatic, we have regular frequent coughing, severe exercise intolerance. They may even struggle to walk, so to speak, without taking breaths, more breaths. They usually have a pretty pronounced increased respiratory rate and effort. And the severity most of the time when I see them is quite severe. Another picture here, the Dust Bowl. This is New York City in 1930. This is ironically what I think about what the horse is breathing in, dust like this every day. So if I were going to put everything together, I have to constantly think about this kind of stuff in my brain as a doctor. I have to think about what allergens these horses are exposed to. Do they have a genetic predilection? We know this in the warm blood breeds, in particularly, we have traced it back there. What pathogens may be affected in the upper airway and lower airway that could be causing this? And then the newest stuff as veterinarians that we're focusing a lot of our attention on, is it affecting the microbiome or the normal flora bacteria that are there in the horse? So like I inferred, we do know that there are some or is some genetic predilection to the inheritance, so to speak, of severe equine asthma or recurrent airway obstruction. Sadly, trying to figure out, is this a mare-based problem? Is this a stallion-based problem, i.e., is it sex linked or not? We're not there yet. So we have a long way to go, but we do know that there is some familial history to some of this. Most of the time, though, when I'm thinking about both of these diseases, even in Ohio, etc., this is what people talk to me about. Horses being fed round bale hay, and they basically eat it like a tunnel, and they're in essence breathing through a vacuum cleaner, and their lungs are the vacuum bag, and they're sucking all that dust particulate and hay mold, etc., into their lungs. I don't want you guys to think that round bales are 100% the problem. They're not. Okay, so please don't crucify me too much for beating on round bales. This can happen in square bales just as easily as round bales on how horses eat. Remember, their mouth is right below their noses. Horses are obligate nasal breathers. They cannot breathe through their mouth. So if they're eating and breathing simultaneously, their head is right in the area of all the dust. So we know that it is still true to this day that whether it's mild or severe equine asthma, there are huge environmental triggers. Inhaled dust out of the barn tends to be one of the major things that we always go back and lean on as one of the inciting problems. So inhaled barn dust, whether that's through hay, bedding, other organic debris, can be major triggers in these horses. Over 50 molds that we know of that can affect them. Inorganic particles that I've already talked about, gases in the barn, etc. And then we have the really bizarre offshoot of this disease. And thankfully, where I live and where I think probably most of you guys live, unless you're from the South, we don't really see this thing called summer pest or associated obstructive pulmonary disease. And these horses get triggered by being out on the pasture. And we think it is likely the grass pollen and the fungal spores on the grass and mixed with the hot humid weather that sends these horses into orbit, so to speak, with the disease. It is a huge problem in the South, and it does cause a lot of horses from the South to have to travel to the North in the summertime so they don't have to deal with this disease. Okay, so from a diagnostic point of view, I have to think of things in a fairly sequential manner. So as a doctor, I will spend a lot of time asking you historical things, may even have you fill out some surveys, etc. These surveys can be clinical scores, they can be scores on presentation of things. Almost always, I'm going to be scoping the horse, both looking at the upper airway and lower airway. And then a lot of the stuff and a lot of my time is going to be centered around collecting some of the airway secretions and looking at those under the microscope. We can do some imaging studies on the horses. I don't do a lot of lung functional tests. We can do it, but they're not super conducive to on farm. They usually have to come into a hospital setting for those to happen. And then last but not least, there are ways to do some biopsying of these horses. Again, these two are fairly invasive, where all this stuff over here is fairly non-invasive. Okay, like I talked about, inflammatory airway disease, remember, is a lower airway disease that tends to be more on the mild side, but the lung does have some functional deficits. Again, remember, from a clinical sign perspective, this is one of the things I'm going to be leaning heavily on. The owner likely will complain of cough, mild nasal discharge, poor performance, etc., whether that's in the show ring, when they're under saddle, or moving at performance speed, whether they're a barrel racer, running them on a racetrack, etc. Again, the signs don't necessarily point to a specific diagnosis or disease. What I do know that cough is pretty good. About on a spectrum, about 16 to 50% of these horses will have a cough, with a mean of about 38%. So a good portion of these horses, the primary complaint outside of exercise intolerance is going to be they have cough. This down here, these horses don't usually display signs of what I call air hunger, meaning that you still can perform the horse at pretty high level, and they don't stop because they can't breathe or they're not oxygenating themselves enough. Whether the horse has mild airway asthma or severe airway asthma, I'm going to work them up the same way. Okay. From a clinical standing, I'm going to spend a lot of my time also sculpting the horse. I'm going to listen to what type of respiratory rate do they have? How much effort do they have? I may even do this down here, which is putting a rebreathing bag on the horse's nose. And the whole goal of that is, right, I can't tell the horse to breathe in and breath hold. Unlike you and I, when you go to the doctor tells you to breathe in, hold your breath so they can listen to your lungs better. The horse, I have to confuse their brain and make them take deeper breaths, and I can do that with a rebreathing bag. So I'm looking for exacerbation in how they're breathing, how long it takes them to recover, etc. Cough, nasal discharge, and along those lines. Kind of the next step is looking at the airway endoscopy. I'll have some pictures here in a little bit, looking at mucus scores, so to speak, in these horses. Um, Again, we have spent a lot of time trying to validate a lot of these things, and most of it is still fairly subjective. Dynamic testing, again, I don't do this very often because it's not really user friendly on the farm. And like I said, these horses need to come into the clinic, and I need to instrument them. It is the best way to diagnose them, but like I said, it's not very user friendly. So in my evaluation, I need to remember that it's typically a multifactorial disease. I need to grossly typically evaluate both the patient and the environment. I need to look at the entire patient, not just the respiratory system, and make sure I'm not overlooking something, rule everything else out, and then I'm going to narrow down and try to diagnose them either as an asthmatic or not an asthmatic. Scoping, like I elucidated to, we spend a lot of time scoping these horses. If you've never seen an upper airway scope, here I'm in the trachea. This is what it normally should look like. And then these horses, as we progress down through mild asthma here, mild amounts of mucus, to more severely affected, and these horses down here are severely affected asthmatics. Lots of pooling of mucus, etc., whether it's in big globs or this continuous train of mucus going down into their lungs. Other things that I look at would be the upper airway and looking at the functionality there, and I have scoring systems for those. Just another picture here, looking at um, uh, fluid accumulation and mucus. We do know that this is well documented in the literature that the mucus score is one of the best things that we can do in these horses in trying to figure out what is going on. So, like I said, most of these horses, if not all, I'm going to try to convince the owner that I need to scope their upper airway. Another picture, again, this one is the same picture that I showed you about earlier. So when we're putting the scope in, if it's a 1 meter scope, I can get about all the way down to here in the horse's windpipe. So I can look at its upper airway here, and I can look at its windpipe or its trachea down here and get a really good idea of what's going on. Is there evidence of mucus there, etc. The other thing that I need to consider, this is all the way back of just going through its nose and looking back at its flappers, so to speak, or where its arytenoids are back here. This horse is grossly abnormal because here's its soft palate down here sitting over its epiglottis. So this horse, while it will have poor performance, this horse likely is not an asthmatic per se, without doing some lower airway studies, but it definitely has some significant upper airway abnormalities affecting the horse. So I need to keep both the upper and lower airway in mind. The RAO horse, or the severely affected horse, if you've ever seen a Heaves horse, you know what they look like. Okay. They have really, really abnormal breathing patterns. They have a significant exacerbation of the abdominal expiratory phase. So typically, a horse does not have to use its abdomen in order to exhale. Exhalation is a passive process, meaning we don't have to contract any muscles to squeeze the air out of the lungs. Unlike inspiration, you actually have to contract your diaphragm to suck air into the lungs. The Heaves horse is backwards. It is both a effort for them to breathe in, and it's a huge effort for them to breathe out because they have to heave or squeeze the air back out of its lower airways. These animals do have evidence of severe airway hunger, and they have to augment their rate and their effort. And you may even see them nostril flare in order to try to suck as much air into their lungs as possible. The really severely affected ones will actually lower their head and basically have a straight conduit from their head all the way into their lower airways. Here's a great example right here of this horse that has a severe heave line. So this is exacerbation of the external abdominal oblique muscles strengthening, so to speak, in a really affected Heaves horse. So these horses, I don't need to do a lot of extra diagnosing. I can basically diagnose them from the outside. Other things that I'm maybe looking for when I'm scalding them is, do they have wheezes and crackles and all that kind of stuff? So giving me an idea, are they trapping some air in their lower airways? I really like giving my clients some ownership in these cases, right? So I typically try to send them home with a questionnaire to fill out. And this questionnaire, it's called the Horsey questionnaire. It's actually developed at Michigan State a long time ago with a gentleman, a veterinarian up there that was very, very interested in equine asthma. And this questionnaire really looked at how healthy the horses were, and it graded them on a scale of 1 to 4. And I have on the next slide, I'll show you, there's lots of questions on there, so to speak, and we can use that grading scale to try to drive down from a management strategy. Do I think these horses have heaves or not? So here's the owner questionnaire, and it talks about time that you owned it, that was a write-in, frequency of cough, evidence of nasal discharge after exercise, abnormal breathing, whether it was at rest, during, or after exercise, what people thought their performance was it seasonal? Did they have other contact with other horses and donkeys from a parasitism standpoint? And what type of turnout and bedding? And so, as you can see, a lot of these numbering next to them, and we coded them. And the more numbers of number fours that we have, right, the more likelihood that these horses were more likely to develop or have evidence of RAO or severe equine asthma. There's a newer scoring system that's fairly similar to that. This one takes a little bit different approach because it only looks at the abdominal breathing pattern of the horse and the nostril component. So again, another very user-friendly thing that I can send home with my clients where they can sit there at the stall when the horse is the most comfortable, so to speak, and grade the horses. And as you can see on this gradar scale down here, 0 normal, 8 very severe, and I'm looking, a total of 8 would be very severe abdominal effort and very severe and persistent nasal flaring. So I can get a really good idea just by looking at a questionnaire how affected the owners thought these horses were. Okay, so outside of questionnaires and physical exams, etc., I talked to you guys briefly about the fact that, we're probably going to be doing some lower airway testing. How do we do it? Two different ways. The most common way is passing this big tube here called a bivona tube. So it kind of looks like a smaller version of a nasogastric tube. It's got a cuff on the end. And so instead of passing it into the stomach, I'm passing this all the way down the horse's windpipe and lodging it in their lower airways. And then I'm instilling some saline in the lower airways and washing their lower airways and then sucking that saline back out. So I can do it blindly with the use of this bivona tube, or I can use a gastroscope and actually do it that way as well. What am I looking for? Well, most of it is, what does the fluid look like when it comes out? Is it more clear like this, or is it more cloudy like this, or is there some blood contamination in it like that? But most importantly, I'm sending it off to the lab and I'm staining these cells, all these cells down here, to look for what is the type of cell that's there, how many cells are there, etc. And typically, I like to count about 400 to 600 cells somewhere in there and develop a ratio because the ratio of these different cell types is how I truly diagnose the horse. So kind of classic results for the mild airway horse or mild equine asthmatic. I don't really have a lot of neutrophils there, and all those neutrophils should be what I call non-degenerate. So they're just normal inflammatory cells there. They have some mast cells, so evidence of some mild airway disease, and then usually very, very few eosinophils. The mild asthmatic doesn't have to follow these exact profiles, but it's pretty darn close. Main takeaway in all of this is the data really doesn't always link me to the most the degree per se in the type of inflammation. So it doesn't necessarily always specify the true pulmonary lesions. And then we are constantly quibbling amongst veterinarians, so to speak, of what percentage of cells should be there. And that's a constant headache that I have. And then last but not least, I don't actually really know what a normal horse looks like because no one really does a lot of work on normal horses. We only look at the abnormal ones. So again, if I looked at the total neutrophil count, most of the time, if they have a few neutrophils, I usually say they have mild bronchitis. They have greater than 20% neutrophils. With mucus plugs, I'm starting to get pretty concerned about significant lower airway disease. And then on the endoscope, I may be able to see some changes in the thickness of the smooth muscle, et cetera. And if I went as far as to take a biopsy, that could be helpful as well. What about the severely affected equine asthmatic? Okay, so the RAO horses, they tend to have an overabundance of non-degenerate neutrophils, and those neutrophils really hone me in on the fact that okay, these airways are very, very, very inflamed. If I start to see some things that I call degenerate neutrophils, then I'm starting to think they may have some lower airway infection as well. And then the classic sign, if you ever have your veterinarian tell you that there's evidence of Kirschman spirals, that is pathognomonic for horses with heaves, because that is telling me that the lower airways those are mucus plugs from the lower airways. What about a tracheal aspirate? This is a BAL here. Here's a tracheal aspirate right here where I'm sticking a needle through the trachea and sucking fluid out of the trachea. Can it be beneficial? Yes, it can be. We do have some studies out there now where I can use a trach wash to kind of point me down the line that the horse may have severe equine asthma. Lots of times people run other blood work. Most of the time, CBC is completely normal unless they have secondary pneumonia. The chemistry is typically quite normal as well. And then your veterinarian may talk to you about running acute phase proteins like serum amyloid A. And again, a lot of times those are either normal to mildly elevated because these are not acute things. These are long-standing diseases in the horse. As far as diagnostic imaging or radiography, I don't typically take a lot of radiographs of asthmatic horses because there's sadly minimal correlation to the stage and the type of disease that they have. It may give me indication of is there actual pneumonia going on in the lung, but it typically doesn't clue me in a whole lot on the severity of disease or what type of disease that they have. The other kind of non-invasive diagnostic test, ultrasonography, so chest ultrasonography, again, cannot distinguish between whether the horse has mild equine asthma versus moderate equine asthma. Unfortunately, I really wish that it did. One thing that the ultrasound can help me with, though, if I see evidence of significant consolidation in the lung, I do know that this horse, while it may have asthma, also has a significant component of pneumonia. Okay, last but not least for the talk is what about treatment, right? Like, it's great to diagnose them, but what can we do about treating these horses? So, treatments, there are about as many tested and anecdotal therapies out there that we can possibly dream up, and there's new ones every single day that are on the nutraceutical side. Sadly, a lot of the nutraceutical stuff, there's basically no clinical or scientific evidence to back a lot of these things up. So just be a little bit cautious on stuff that you're buying off the internet, et cetera. There may not be a lot of data supporting the use of it. One of the hallmarks to treating both of these diseases is client compliance. I have to have the client that is willing and able to accept that there's technically no cure for either one of these diseases. And one of the main strongholds for treatment is environmental management changes. I need to change how these horses are housed. I need to change how they're fed. I need to change what type of bedding they're on, etc. So a lot of times the treatment is targeted at the local inflammation in the lower airway to try to stamp down the severity, but it doesn't make the horse go back to normal, unfortunately. So the horse will live with this the rest of its life. It's also vitally important that the owner recognizes that medical therapy only provides temporary relief. It is not curative. Medical therapy is considered to control slash provide symptomatic therapy. So a lot of the times when these horses come into me at the university, yes, they do require some symptomatic therapy because they're working so hard to breathe. I have to calm them down, et cetera, and get their work of breathing slowed down. But it is absolutely vitally important that the owner recognizes that without environmental management changes, medical therapy will not provide long-term relief. It is only days of treatment, so to speak. Ideally, I get weeks to months, but realistically, in the severely affected one, I have very short, limited time that the treatments actually work. It's the environmental control and management of the horse that really changes things. So, as I talked about, environmental management is the cornerstone. I need the horse to breathe fresh air, and air hygiene is paramount. So ideally, the horse is managed outside 24/7, i.e., no stall. If it has to go in a stall, ideally an end stall, stall with lots of windows, a stall away from high traffic areas where there's a lot of barn dust. The horses need to go outside when the barn's being cleaned, the stalls as well as bedded, and uh, the barn blown out, whatever, the floor being swept. Ideally, no fans on these horses at all. If you need to put a fan on them, I need to blow the air across the horse, not into its face. Dust-free hay. They make hay steamers. We can soak it. Ideally, no round bales, but if you live in central Ohio right now, where we had a massive drought last year, hay is a premium right now. So I have a lot of horses that are getting fed suboptimal hay. Okay. Ideally, maybe a complete feed, etc. But again, I need to optimize ventilation. So stalls like this, where in essence they only have their outdoor is in essence right outside of their stall, and they have air movement across the top of them, and they're not breathing air from inside the aisleway, so to speak. Again, one of the major therapies that we lean on for rescue is steroid therapy, which is a huge anti-inflammatory. I'm trying to reduce the lower airway inflammation, but I'm not making the horse back to its normal self, i.e., I'm not reversing the remodeling of the lower airway. The steroids can be given inhaled, they can be oral tablets, they can be intravenous or intramuscular. Um, um, as far as the different styles, I don't have a lot of huge predilection to lean on one or the other. But one thing that I can say, inhaled steroids have the least amount of side effect systemically to the horse, which is really, really important. They're the hardest to give and they cost the most, but they have the least systemic side effects, which is really good. How do we get them inhaled into the horse? You can lean on small human inhalers, and we do make delivery devices for those, like the Aerohippus is a pretty common one where you can put the inhaler in the delivery device, and then that fits over the nose. Um, uh, we used to have the servo, and unfortunately, we're not. That's not being made anymore. I did use that quite a bit, and was pretty successful using that. And then we have micro atomizer masks that the horse can wear. This is the Flexi Neb, but there's several others out there on the market, etc. The whole goal in any of these is to deliver a large amount of steroid at the ideal particle size that the lower airway, so that the atomized steroid gets all the way into the lower airway. Another major style of drug that we use are the beta agonistic drugs, clenbuterol or venipomin, which is right here. It's a syrup. that we can give to the horse. It's the only one that's actually approved to be used in the horse, and it does improve mucus clearance. Um, we can use human form of albuterol. Here's an albuterol inhaler right here, or you can get these are children's size liquid albuterol that can be nebulized as well. And then salmeterol here is also another aerosolized. It's quite a bit more expensive than albuterol, but beta agonistic drugs work relatively well. Some significant side effects of beta agonistic drugs in the horse. It does have other systemic effects, so I have to be a little bit careful keeping them on beta agonistic drugs. Other rescue meds that you may have had your horse given, Buscopan. I love using this drug in the acute asthmatic horse because it does provide some smooth muscle relaxation. Kind of opens these lower airways up in these horses, and it helps with their decrease of respiratory rate and effort. Prior to Buscopan being available in the United States, I used a lot of atropine and a lot of glycopyrrolate. But since Buscopan has been around in my practice 10, 12 years now, legitimately, I use very little atropine or glycopyrrolate. There are some other stuff out there, some inhaled drugs, ipratropium. It is a pretty good bronchodilator. And if you use some compounded drugs, you may find that there's some ipratropium in it. It does work pretty well, and it does help open up the lower airways. Some other stuff that we do use every now and then, pentoxyphylline does provide a little bit of bronchodilation. Not a lot of evidence pointing to the fact that it decreases lower airway inflammatory cells. And it's not the mainstay therapy, meaning I'm not going to use this as a sole drug. We did borrow some stuff from the human side. They're really hard to get anymore. But these Intel inhalers, lots of people, lots of human asthmatics were on Intel, which is cromolyn sodium. It's a mast cell stabilizer, but they really don't make that very much anymore. So we've gone to more of these compounded drugs that have multiple drugs in it to be nebulized directly into the horse. Last but not least, you're getting towards the end. Oxygen therapy. Now, while the horse is in the hospital, I can put it on oxygen, right? But I can't have a horse wheeling an oxygen cylinder around when it's out in the pasture, so to speak. So oxygen therapy, it's a non-invasive therapy. I put these nasal cannulas in the horse's nose like this and kind of point them down into their windpipe to help super oxygenate their lower airways or get more oxygen into them. So that can help them quite significantly, but again, not conducive for on the farm treatment like some of this other stuff. So this is an in-hospital only. Mucolytics, there's basically no evidence for the mucolytics out there. One of the big ones for a long time was Spectus, which was guaifenesin powder or guaifenesin liquid, but most of the time it was powder that you would feed to the horses to try to get it to work as an expectorant. Some of the other stuff that a lot of people are starting to investigate, and hopefully, probably in the next 20 years, we'll have some fairly good literature out there about antioxidant therapy. There is some stuff about feeding omega-3s, omega-3 fatty acid supplementation, and helping these RAO horses. Lots of people looking at acupuncture as well. And then I'll say one mild comment here, immunotherapy. We will at times do classic intradermal skin testing on these horses to try to see if I can desensitize them, etc. So the summary, equine asthma is here to stay. I'm sad to say, probably in my lifetime as a veterinarian, we're not going to make this one go away. It affects a ton of horses that we know of. It's probably going to continue to affect a ton of horses, and a lot of that is based on how we manage it. We're not super good at knowing where we are, but we think about 25% of the horses are affected. A lot of other horses are likely affected, but they don't breathe real hard, so they're not all the way up to their maximum amount of oxygen that they need. So there's a lot of subclinical horses out there that I miss because they're just not worked very hard. Diagnosis can be challenging because it requires some fairly specific things, but they're really effective ones. We have a great idea just by watching them breathe. The owners have to accept and understand that there is no cure. This is a management disease. It's not a cure disease. Medications are only for the severe cases or the cases that require rescuing. Most of the time now, I'm trying to get owners to go down more the inhaled side of things versus using injectable drugs because of the systemic side effects of the injectable drugs. Medications cannot be continuously used because they build up a dependence to them. So the lower airway inflammation doesn't go away with the same amount of drug given, which is a huge problem that we have. In really environmental and daily management is the cornerstone of trying to treat these horses on a daily basis. So with that, I'm going to stop here for questions and open it up to you guys. So please ask away. Julia, do you want me to stop sharing my screen?
You can stay right there for a minute.
Okay,
Thank you so much, Dr. Schroeder. It was a wonderful talk.
you're
Now,
welcome.
you're welcome. Now it's your opportunity to ask some questions. For those listening on Facebook Live, please ask your questions in the comment section and we'll read them to Dr. Schroeder. So I do have one
Okay.
already in the Q&A. So those of you here on Zoom, just use the Q&A feature to ask your questions. So the first one is, how difficult is it to allergy test a horse?
Great question. There's two different, classically, there's two different styles of allergy testing in the horse. We have the very traditional intradermal skin testing, like what you may think about for children, where there's 50 to 100 different allergens, so to speak, and that can be to bugs and mites and barn mold and dust and etc. And those are in really small aliquots, and we put those usually um, um, uh, if we think about a horse's neck, we shave the side of the horse's neck, and we put small amounts of these irritants, so to speak, under their skin, and then we measure them using a set of calipers, so to speak, in essence, a fancy ruler, and looking at them fairly frequently to see how much they react to it. And then, which would be very similar to how they do this in people and children, etc. And then, based on how big of reaction they have, that would tell me as the doctor what type of allergens do I need to mix, so to speak, in a syringe to then have you give um, desensitization shots, so to speak, to the horse. And we typically start those bi-weekly. And then as we go out a couple months, we'll be in the once a month, and then hopefully every few months as a booster to keep the immune system responsive. So that's the intradermal testing, and then there's a different style, and that is blood testing. The challenge with blood testing is it doesn't always uh, give you quite a complete picture as what the classic intradermal testing does. Kind of the same idea, but I'm looking at it in the blood, which is a bit different way of seeing how the local skin, which is similar on the skin of the horse to what they have internally down in the lungs. So if I had my druthers, so to speak, on how I could convince somebody, I would lean for intradermal skin testing. Can be done, usually can't be done on a farm per se. So usually have to make an appointment with a referral hospital, whatever, to have it done. They're very common. Most every place is quite adept at doing this.
Perfect. Are there particular inhaled steroids that give better results?
Uh, yes and no. It kind of depends on, are you using human drugs versus veterinary drugs? If you're using human drugs, the most common that you would hear a person use for themselves, so to speak, is what we call Flovent, which is fluticasone. And those come in those little inhalers that you see people have, whether it's in their book bag, purse, whatever. Those work very well. And we, for years, managed horses that way. With inhaled steroids that way. And we have various delivery devices, Aerohippus, etc., that work very well to get the horse to breathe it in. The disadvantage of those, one, is cost because they're human drugs, and veterinary insurance doesn't pay for those drugs because they're human drugs. And two, the amount of drug in there, i.e., puffs, is not super high. There's only about 200 puffs in there. So if you're giving a horse 4 to 6 puffs twice a day, you're going to burn through that inhaler pretty quickly. So they tend to be a little bit cost prohibitive. But again, understand, for years we managed them that way. Switching gears to the more micro atomizing style devices, flexing neb. There's many of them on the market. They all have their pros and cons as far as delivery devices. But as far as steroids, usually we are using injectable steroids. So the most common would be the 2 milligram dexamethasone or the 4 milligram dexamethasone that we're atomizing and having the horse breathe that in versus giving it IV or in the muscle, etc. We also have budesonide that works very well as well. And I'm sad that BI no longer makes the Acervo because that drug that was in there was budesonide, worked really, really well in these horses. And we got horses under control. So now to use that drug, I have to use a little bit different style delivery device. So do I have a preference? Not really. Kind of is cost dependent. And what do I think the owner can get done at home?
Thank you. Dr. Skelly, do we have any questions on Facebook?
No, we don't. We don't. But I actually had a question.
Sure.
So when we're talking about feeding horses hay, and you talked about the steaming or the soaking, is there any, has anybody looked at, feeding round bales and feeders that were specifically designed to horses, maybe uncover if
Yeah.
that has any
Yeah.
effect?
Great questions. Now I don't know all the literature, but no, not that I'm aware of.
Okay.
So, I mean, a great question. Like, so if we use the hay huts, so to speak,
Right.
where I'm taking away the rain component, does that change the horse's local airway, or do I switch to the horse version of the hay saver, which the hay saver was initially made for cattle, where it's a cone style round bale feeder, where the bars are pretty close together, etc. So they can't pull the hay out and then lay on it per se and waste hay that way. I am not aware that anyone has put particulate measuring devices on those styles of feeders to see, okay, can I more safely, if I have to feed round bale hay, because I understand if you have a couple hundred horses and you are feeding horses every day, feeding square bales is not easy. So, I have to keep in mind that a lot of people out there feed round bales, they feed big square bales, etc. So, like we have to be cognizant of the fact uh what's going on here. As far as I'm aware, I don't know anyone that has actually put a dust particle particulate measuring device in that general vicinity. I would say if somebody's like, can you please help me design this? Get the round bale feeders outside, get them elevated off the ground. Ideally, make perfect hay if you can. I understand how difficult that is. And then my goal always, if I'm feeding round bales, I want those round bales to be turned over every 3 to 4 days at most.
Yeah.
So the round bale's not out there for 2 weeks.
Yeah. Yeah. Yeah, at least we always talk about, at least 4 to 7 horses per round bale.
Yes.
Get it eaten up quick. All right.
There's a really good question. Let's just do one more because I know we're over our time here. What bedding considerations would you recommend?
Oh, great question. It can be all over the board. If I'm talking about the severely affected horse that is in my hospital, they have no bedding in their stall. Because I'm just trying to eliminate as much dust as I possibly can because these horses are in essence a heaves crisis. What about at home? There's several different kinds that I would lean on. And it may be area specific, so to speak, i.e., what part of the country are you in? Because these products aren't necessarily ubiquitous across the U.S. or even across in other countries. There is a pellet style of bedding that you can wet down that in essence looks like kitty litter, so to speak. It's like clumping horse bedding that works really well. The key is you have to water it down and you have to keep it fairly wet, not sopping wet, but you have to keep it kind of damp in order for it to work well. So if you're living in Arizona or the South or something like that, you may have to water it a couple times a day. There's also paper bedding that works pretty well as well. Um, there are some minor caveats with the dustiness of that stuff. It can be a little bit dustier, etc. You also have to take into account the local horses around that horse. So if you have normal sawdust or straw in all the other stalls, but only pelletized bedding, so to speak, in the horse that's severely affected. Be cognizant of the fact that there is dust that is blowing out of the other stalls into that affected horse's stall. So, but if I had my choice, the pelletized bedding, I like that quite a bit. The last thing that I will say about this, and this has nothing to do with uh, asthma. I have had horses eat that stuff and they will colic off of it because it expands. So be be a little bit cognizant of that too. All of a sudden, if you're missing a bunch of bedding in the stall, the horse probably ingested it.